Assalamu alaikum. Welcome. In this session, we will learn about airway management. So the ABC, first thing is airway. So how to manage the airway? So why is it important to manage the airway? Yeah, so you can give the oxygen, right? So when you give the oxygen, when you do the compression in the beginning, the blood has some oxygen, you can use it to nourish the organs. Later on, the oxygen will not be enough for the organs, so then you have organ hypoxia. So the organ hypoxia will lead to death, right? So you don't want that. You want to give proper oxygenation. Without open airway, no benefit from the oxygen, right? So how to open the airway? How to clear the airway if there is obstruction, and how to maintain the airway open. Then we will learn how to give oxygenation through various devices even if the patient is not breathing. So this is the point of this video. Just watch this video and we'll discuss the skills individually.
Managing a patient's airway is a fundamental life-saving skill, one that both basic and advanced healthcare providers should be able to perform well. Airway management is one of the key interventions for BLS and ACLS. It is critical before, during, and after cardiac arrest. The optimal method of managing the airway will vary based on provider experience, training, scope of practice, EMS or healthcare system protocols, and the patient's condition. When giving ventilations, healthcare providers should avoid excessive ventilation or administering tidal volumes that are too large. Not only can this cause gastric insufflation and aspiration of gastric contents, but excessive ventilation also increases intrathoracic pressure and decreases venous return to the heart, so it lowers cardiac output and the patient's chance of survival. Tidal volume should be approximately 500 to 600 milliliters, enough to see the chest rise. This is about half a squeeze of an adult ventilation bag. Once the airway is open and clear, you may consider use of an airway adjunct to maintain a patent airway. There are two types of airway adjuncts, the oropharyngeal airway, or OPA, and the nasopharyngeal airway, or NPA. OPAs are commonly used for patients who are unconscious and have no gag reflex. NPAs may be used for conscious, semi-conscious, or unconscious patients with or without a gag reflex. The OPA is a J-shaped, single-use, disposable plastic device. Here's how to choose the correct size OPA. Place the OPA against the patient's cheek. When the flange of the OPA is at the corner of the mouth, the tip is at the angle of the mandible. A properly sized and inserted OPA results in proper alignment with the glottic opening. Once properly inserted, the OPA holds the tongue away from the posterior wall of the pharynx. It also provides access to the throat for suctioning and prevents the patient from biting an advanced airway. The NPA is a soft, curved, hollow tube that can be inserted through the nostril to facilitate ventilation and suctioning. Unlike oral airways, NPAs may be used in patients who are conscious, semi-conscious, or unconscious, with or without a gag reflex. In choosing the correct size, make sure that the length of the NPA is the same as the distance from the tip of the patient's nose to the earlobe. When inserted correctly, the NPA should reach beyond the nasal cavity to the pharynx, providing a clear path for ventilation and suctioning. After inserting either an OPA or NPA, it's important to check whether the patient is getting adequate ventilation by listening for breath sounds. During resuscitation, patient ventilation is commonly provided with a bag mask device. Let's see how to properly use a bag mask device. First, position yourself directly at the top of the patient's head. Place the mask over the patient's face. Before providing bag mask ventilation, the provider must first perform a head tilt and then press the mask against the face while lifting the jaw into the mask. This is best achieved by forming a C with the index finger and thumb of one hand on the top side of the mask at the bridge of the nose. This motion firmly secures the mask to the face. At the same time, the three remaining fingers form an E and should be used to lift the jaw, opening the airway. While maintaining a tight seal between the patient's face and the mask, and maintaining a jaw lift to open the airway. The provider should squeeze the bag, taking about 1 second to deliver 1 breath. For a patient who has spontaneous circulation but needs ventilatory support, the provider should give rescue breaths at a rate of 1 breath every 5 to 6 seconds. An effective breath results in visible chest rise. The most effective way to deliver bag mask ventilation is to use the 2-person technique. The first provider focuses on keeping the airway open and securing the mask, while the second provider delivers ventilation with the bag. The first provider uses both hands to seal the mask to the patient's face and lift the jaw. The thumbs and index fingers of both hands each form a C, ensuring a good mask seal against the face, with the 3 remaining fingers of each hand forming the E, lifting both sides of the jaw into the mask. The second provider squeezes the bag, enough to cause visible chest rise. There are several possible indications for insertion of an advanced airway. These include difficulty providing effective bag mask ventilation, patients with actual or potential airway compromise, particularly with long transport times, or the need to isolate the airway. Healthcare providers who use advanced airways within their scope of practice must maintain their skills by using them frequently. When choosing to use an advanced airway, you need to be confident that it is inserted correctly and that you're providing effective ventilation while avoiding excessive ventilation. Watching for chest rise, checking for bilateral breath sounds, and listening for gurgling sounds coming from the stomach can help you confirm the placement of an advanced airway. Beyond these clinical assessments, there are several devices that can help you determine whether you have inserted the airway correctly. Waveform capnography monitors how much carbon dioxide is exhaled by the patient. The American Heart Association recommends using waveform capnography to confirm and monitor the correct placement of an endotracheal tube. Scientific studies have not yet validated waveform capnography as a method of confirming proper placement of supraglottic airways. However, effective ventilation through these airway devices should produce a capnography waveform. A normal end-tidal CO2 waveform looks like this. The measurement of the amount of end-tidal, or exhaled, carbon dioxide can be shown as a waveform, where the carbon dioxide level goes up when we exhale and falls back to 0 when we inhale. Even when healthcare providers are properly ventilating the patient, chest compressions will produce a low end-tidal CO2 reading because even the best CPR produces cardiac output and pulmonary blood flow that's about 25 to 30% normal. In contrast, ROSC can cause an abrupt increase in end-tidal CO2. Waveform capnography devices that display both a waveform and a number will give you the most comprehensive information. Humans with healthy lungs have a characteristic waveform that is divided into 4 phases that occur during inspiration and expiration. When the patient first begins to inhale, the curve falls sharply to 0. As the patient continues to inhale, the reading on the monitor should remain at 0. When the patient first exhales, the initial portion of the breath consists of the air in the dead space from the breathing tube and the trachea. As air from the alveoli begins to empty into the circuit, carbon dioxide levels start to increase. This is shown as an upward deflection at the beginning of the exhaled carbon dioxide curve. As exhalation continues, carbon dioxide continues to pour out of the lungs until the next breath is initiated. The highest value in the curve is called the end-tidal CO2. For patients with normal perfusion, an end-tidal CO2 reading of less than 35 millimeters of mercury indicates hyperventilation. A reading of more than 45 suggests hypoventilation. Sudden changes in the waveform should trigger immediate reassessment of the patient. When the waveform jumps up during resuscitation, this may indicate ROSC. Airway skills are fundamental to successful ACLS. Proper training, frequent practice and use, and logging both successes and complications can help build your skills and lead to more comprehensive, successful patient care.
So we saw in this video multiple skills to managing the airway from beginning to end. So first is to open the airway. So how to open the airway? First, after you do the BLS survey, you confirm the patient is not breathing. So you have a problem with the airway, right? So he's not breathing. He's have a problem with the airway, or he is unconscious, but he cannot breathe. So how to know that? Rule out airway problem by opening the airway. So how to manually open the airway? We do the head tilt, chin lift technique. Yes. Head tilt, chin lift technique. What is the components of head tilt, chin lift technique? So I need every one of you. Your name? Marceline, please come to the mannequin. Your name? Sayeda. Bro. Yeah. So we will perform the head tilt chin lift technique. So to do the head tilt chin lift technique, you do it. How to do it? You put one hand on the head and the other hand on the chin. Pull the chin up and open the mouth and tilt the head back. The same motion. So try to do it. Yeah. Okay, try to do it in this mannequin. Try to do it in this mannequin. The head will move with you. Do it with this mannequin. The head will move with you. Yes, like this. And open the mouth at the same time. What's the benefit of this motion? You are clearing the obstruction. What obstruction? Yeah, you have the tongue. What is the problem with the tongue? The tongue is a muscle. Okay? With the patient losing control, it will fall back on the throat and block the throat. When you do this motion, the tongue will not block the throat. You will have a gap between the tongue and the back of the throat to allow the air to pass to the lungs. So now you are ruling out the obstruction by the tongue, which is the most common cause of airway obstruction. Why? Simply, it's in your mouth. Alright? So, it is not needed to be put in your mouth. It's already there in your mouth, so it will block your airway. So, when you open this, you do this technique, you clear the obstruction by the tongue. What if the patient is a victim of trauma? You have a risk for cervical injury. So, what's the problem with the cervical injury? I want to stabilize this injury. I don't want to move this injury. So, what should I do? Will I compromise the fracture? No. I will do the jaw thrust. How to do jaw thrust? Both hands with these two middle fingers and index push the jaw angle forward. So you are stabilizing the head with your palm and your fingers pushing the jaw forward. You are not moving the head. If you move the head, means you are making a mistake. You don't want to move the head or the neck. You want to just only move the jaw, only the jaw. So when you move the jaw will take the tongue also forward because your tongue is attached to your lower jaw or nearly attached to the muscles in the lower jaw. So you are moving the tongue forward, also removing the obstruction, allowing the air to pass. Now you did open the airway, right? So you have first choice, head tilt chin lift, no risk for cervical injury or jaw thrust for cervical injury. How to know if there is a trauma, history of trauma, you saw him fall down, you saw hematoma, you saw things that indicative of trauma. You go for safe way is jaw thrust, okay? So this is the opening the airway. Now you want to clear the airway. Let's say there is another obstruction, a foreign body or secretions. So how to clear this obstruction? First you can use the suction. The most common second thing after the tongue is your own secretions, the bleeding, the saliva, right? Aspiration, food, all of this can cause obstruction. So how to clear it out? By suctioning. So use the suction. You have different devices for suction, either a soft catheter or a rigid catheter. So the rigid catheter allow for high pressure suction or thick secretions, thick material, allow suction for thick material, and allow better control to go to the crevices of the mouth. If you, but it has a problem. You cannot use it for nasal suctioning, for example. You cannot go deeper. Yeah, you cannot go deeper. So you can use the other one, but the other regular suction catheter cannot withhold a higher pressure suction. So it has an advantage and disadvantage. So you use whatever suitable for the situation. So use both now. First, try the anchor suction. Try the anchor suction. Move to the other mannequin. It allows the airway mannequin for the insertion and suction. The other mannequin. So now you do the suction. Adjust the pressure, etc. Then, if you need suctioning with the other catheter, provide the suction. Okay? Yes, especially if you are in trachea. The problem, the point here that you are relieving the obstructions. Okay? You are doing this until you remove the obstruction. Okay, so now you opened the airway and you clear the airway. Then you will not keep holding the airway by your hand all the time, so? Because now you open the airway, you need also to do oxygenation. So how would you provide oxygenation with your hand busy? You need something else to stabilize the airway open. So you need an airway adjunct. Airway adjunct. There is basic airway adjunct and there is advanced airway adjunct. So basic airway adjuncts like oropharyngeal airway. So what's the indication of oropharyngeal airway? Patient has obstruction airway and he is unconscious. No gag reflex. No. Huh? عشان بس دي ما تركبش هنا. طيب. Okay. So you have the Okay.
Can you come please يعني to each mannequin? Only we have in each table one airway mannequin. So the two of you will practice the device which Ahmed explained. Okay?
So just first do the opening airway, the same like we explained. So do the airway opening. Hit the chin left, yes. Hand on the mouth, yes, exactly like that. And just with your thumb open the mouth. So you do like that. Sorry. Okay, and open the mouth. Okay. And do the jaw thrust. Let's do the jaw thrust. Jaw thrust under the jaw angle. How to find the jaw angle? Here in the back, this way. But don't open it. You stabilize the hand. With the palm of your hand. The hand, put it back. Do it like that. No, don't move the head.
For this patient with spine injury.
If you move the head, exactly like that.
Yeah.
Move the head and open the mouth. Sorry, move the jaw forward and open the mouth. Like. Okay. So this is it.
For this patient with spine injury.
Okay, so now we have opened the airway. Now you do the suctioning. You did the suctioning, you clear the airway. If there is a foreign body, you can remove it. If you saw a foreign body, you can remove it. If you cannot see a foreign body, don't do blind finger scoop. Don't do blindly looking for foreign body. Put your fingers, look. No, don't do that because you have a risk either induce gag or you are pushing this foreign body inside because you are doing blindly. Yeah, or you may hit your finger. So now you did clear the airway. Now you want to maintain the airway. So open, clear, and maintain. How to maintain the airway? First, the OPA. If you have no gag reflex, How to measure it? From the mouth to jaw angle. From mouth to jaw angle or to the mandible. So this, you do the proper size. Smaller size will block the airway. Larger size also obstruct the airway. So you don't want wrong size. You want the right size. So try to do it now. No, you don't do it because the mouth go in this direction. The curve is upside down. Okay? So try it in this mannequin.
This is the airway mannequin.
The mannequin, this mannequin accept the
yeah, this one is a closed mouth.
Both of the switch. Yeah, when you insert it upside down first. Why? To avoid the tongue. See, the tongue is down. Look at me. The tongue is down like this, in down, curving down, and the airway is curving up. So you're going like this. Then you switch, you fix it. Now, if you go this way, see, you're pushing the tongue. So the tongue in the mouth like this, right? It's curved up. So when you push with the same direction of your airway, that's this way, you are pushing against your mouth, your tongue. You have to go like this to avoid the tongue, then correct it. Okay? Then rotate it halfway, not all way. You rotate it halfway, not all way. When it's halfway in. Okay? Because when you go inside, it is narrow space. You are doing friction in the throat. You want it to rotate it inside the middle of the mouth. If you go deep, you are going in a narrow space. When you do rotation, you injure the patient throat. Okay? Try it, both of you. Okay? Now if you have your patient starting to move, you are doubting the patient have gag reflex, etc. So you will use the MPA, nasopharyngeal airway. Another contraindication for nasopharyngeal airway is head trauma. Head trauma is you have a risk for fracture base. Fracture base, the base of the skull is when you go in the nose, you are just touching the base of the skull. There is a bone protecting the brain. If this bone is fractured, you have a risk for penetrating the brain membranes that's separating the skull from the nose and causing infection, etc. So you don't want that. So only if you have cervical or fracture or fracture base or trauma to the head, you are doubting, or you saw the patient having secretions or oozing secretion, CSF fluids from the nose or the ears. Now you are doubting fracture base. So don't use the MPA. Same also don't do nasal suction. Don't do nasal suction. So this is the way you balance out your options. Then you go for the MPA. You don't have that risk, you go for the MPA. When you go for the MPA, lubrication. Use lubrication because in the mouth you have saliva. In the nose you have less lubrication, less mucus, and narrow space. You don't want to cause injuries and bleeding, so you lubricate. This is the spray for the lubrication. Lubricate the tips, the tip of your MPA, and you insert it innocent, just like that. You hold it like a pen and rotate. If you have obstruction, take it out, rotate, put it in back. Then, if it is not going in this side, go to the other side. Or use smaller size MPA. The aim that you open the airway to the outside, so you can deliver oxygen. Okay? So now you have your airway secure. Now we want to give oxygen. Let's say the problem of this patient that you have a blockage in the airway. If he starts to breathe and after you open this airway, what do you need to provide to the patient? Oxygen. Don't assist him in breathing. He breathing normally, it's better for him. So what you